Okay, welcome. DENT 1159, Project 1. We made the custom trays the previous project. Custom trays went to the dental office. The dental office utilized some type of border molding impression, either with the compound and a combination of heavy body and light body PVS, zinc oxide, polysulfide rubber, or a polyether. These days, mostly it's a PVS, the combination of heavy and light, depending on the mobility of the tissue and whether the dentist wants to achieve a mucostatic impression or a dynamic functional impression. We're going to assume that all these structures are firm. The PVS was utilized. You can see that this model had a nice land area created. This was one of my clients from a while back. Now this may now be a departure from what you have been used to in the first semester. So I had previously just made my light cure base plate. And the base plate, as you can see, is just shy of the soft palate. Even though my final impression, I border molded and took an impression of the soft palate, I'm hoping to engage that slightly with the denture to increase adhesion if the patient can tolerate it. If the patient can't tolerate it, I'll be finishing somewhere here. I'm going to add a wax extension, and then therefore chairside, the dentist and or myself or denturist is going to see if we can engage some of the soft palate beyond the vibrating line. When we look at our early dental technology textbooks, it always says, 2 millimeters anterior to the palatine fovea, which is somewhat anterior to the vibrating line, which is fine. But I'm more of the practical approach, where if I can engage further, I will. I've noticed with my own experimentation, if I can engage here, I'm going to get more adhesion. If the patient can't tolerate it through a hyperactive gag reflex, then I'll shorten it. But you can see where I think the denture will finish here, which is a junction of the hard and soft palate. And I've trimmed symmetrically now, symmetrically is the word, of my base plate anterior to that. Here I've trimmed my base plate way shy of the ridges here. I don't want to jeopardize my final impression by engaging undercuts with a light cure tray. The occlusion rim is a tool to the finished product of a denture. I'd hate to, like I say, compromise the final impression for the sake of a bite registration. So two things. I want to cut it short so I don't engage undercuts and therefore jeopardize by abrading, chipping, or scratching my final impression. Number two, I want to alleviate a lot of room here because I don't want the base plate to interfere with my denture setup. Number two. Number three, I can engage any undercuts with wax. Therefore, that'll be a lot more pleasing to the patient, and then my occlusion rim will be that much more, have that much more retention. My maxillary occlusion rim, you have to remember, is going to go through 3 registrations: centric relation, facebow transfer, and protrusive bite records. Memorize those 3. Those are 3 bite registrations: centric relation record, facebow transfer record, and the protrusive bite record. Now, those of you in the marketplace saying, what's he talking about? I work in the lab. I barely get the models even put together. You're correct. But this is school, and we must consider what that occlusion rim is academically for. If you're using in the marketplace a preformed rim, meaning a lot softer wax, those are determined and developed for the dentist that needs to adjust it quickly. That soft wax, there is no way that is going to survive 3 bite registrations. If the dentist is just taking a bite record, hopefully a centric relation record, then that's fine. But if we try using that wax as the setup wax, I think that'll be compromising. So to belabor my point here, actually, I just finished this here. in the laboratory. So let's have a look at this. This will really kind of make sense to you. So I inherited this occlusion rim and bite registration from the dentist from another laboratory. And we can look at it here. It is a light cure base plate, and the light cure base plate goes all the way above the sulcus. Where's my model here? Oh my goodness. And the dentist says, Paul, can you please set up for try-in? Sure. So I'm going to set up this for try-in. Here's the case here. It's not on a semi-adjustable articulator, it's just on a plain line articulator. It is a huge class 3 modification 1 or long span class 4, which we're going to discuss. So therefore, the instructions from this dentist should give me minimum overjet, minimum overbite, etc. You can see the undercut here that was chafed by the occlusion rim, and maybe that's why they made it out of die stone. So if I barely squeeze this onto the model, this was made from another laboratory, which is a graduate from our class, I'm sure. When I assess this occlusion rim, you can see that there's a piece missing that they filled in with wax. This was actually the occlusion rim. How symmetrical is this? Okay, easy to be a critic, but I have to now use this for my setup. So now the dentist is saying, Paul, when I'm done with this laboratory, can you take this over? I'm like, okay, sure. But then I say, Doc, there is a midline. Where's your midline? Sent it back. He gave me the midline. I've marked it here. I go to do the setup. You can see that this is hard plastic. Let me use the instrument. This is hard base plate. This is going to now interfere with my setup. I'm going to have to over-reduce my denture tooth. So I made an executive decision that I tossed that away. I made my own base plate that I'm engaging short of the incisive papilla. And then therefore, hopefully you can see, I don't know if I hold it up to the light maybe, that there is a very thin area by the incisive papilla. And therefore, I was able to do the setup and maintain the length of the prosthetic teeth. If I put my thumb over here, simulating the smile line, I'd hate to compromise the length of these teeth and then, end up with a gummy smile. Why? All the way back to the base plate of the occlusion rim was the culprit. The base plate of the occlusion rim shouldn't dictate my aesthetic control of the setup, especially in these day and age when the treatment plan is really motivated by aesthetics. Function is secondary. Is my overbite and overjet here a little too long for this case? You can see where I've marked it, possibly. But with some experience of this dentist, I know he's going to forego the function for the aesthetics. So I can't go end to end completely, but I've just gone bare minimum overbite overjet with some crossbite here on the back section. But the crossbite is a conversation for our project 4. Let's get back to project 1. And I hope that made some sense to you. Actually, I have another example of that. So this denture is very similar, a class 3 or a long span class 4. The patient's retained 7s. But I just want to show you, this denture was just finished. But you can see that right here by the incisive papilla, or right here on the neck of the teeth, because of the base plate was out of the way, I was able to set the teeth right on the ridge. There's less atrophy that occurred here. My base plate's not controlling my aesthetic desires in the setup. It's not minimizing the length of the natural teeth. Okay, I'm sure you've noticed this is C4. It's a very dark shade. But that's another issue. The issue I'm trying to talk about here is the length of the neck of the teeth is maintained because I didn't engage here with my biplane. So my approach to dentures is very practical. I'm the one that's going to set the teeth up, so therefore I want to make my job easier. And we talked about the human condition in need of hedonism, or do we want to be masochistic and painful in our job? No, I want things to be great. So I'm engaging here with free-flowing wax, the undercut. Again, I'm making the occlusion rim. One thing I failed to mention here is that the base of the model should be parallel to the ridge. I've trimmed the base of the model. parallel to the ridge, or at least smoothed it off from our puck. Because we're going to make an occlusion rim of average dimensions. The average vertical dimension of the human being from just off-center of the labial sulcus is 22 millimeters for the maxillary and 18 for the lower, making a combined 40 millimeter starting point of vertical dimension of the average person. We don't know if this is an average person yet. I'm creating an occlusion rim for the dentist with a starting point of 40 millimeters of vertical dimension, or 22 in the anterior. We know from our anatomy class that the maxillary edentulous ridge is part of the skull. So therefore the bone makeup is primarily of a cortical bone. The atrophy pattern of the maxillary edentulous arch is not just straight upwards, but also inwards. So we're going to discuss some different philosophies of denture setup from Dr. Gerber, Dr. Gysi, Dr. Hildebrand, Dr. Haller. I'm missing a couple others, but those are primarily the main ones. Dr. Fehr, F-E-H-R, about average dimensions and occlusal philosophy of the denture-bearing surface and all philosophies of group function. We discussed the other day that dentures are set up in group function, bilateral balanced occlusion. We must believe and buy into the fact that the condyle, or the head or neck of the condyle, and the glenoid fossa determines the pattern of movement of the mandible. And any interference of this free mandible movement down the anterior wall of the glenoid fossa will deflect and create hyperocclusion. Hyperocclusion will be translated down onto the ridges. Any hyperocclusion translated down to the ridges will create instability of the denture, number one. Over long term, exacerbate extreme atrophy, or elevate the atrophy of the maxilla or mandible ridge, as well as create sore spots on that ridge prior to that atrophy occurring. A small amount of pressure on the alveolar ridge will stimulate some osteoblastic activity and maintain bone height. Any excessive forces onto the ridge will escalate bone atrophy. Our job as the dental technician and or the dentist as part of the team is to maintain what the patient has and do no harm. So anything iatrogenic we're going to avoid. So for the dental technician, the answer of "I didn't know" is not good enough. We must know, and therefore we can act responsibly. So, if I could use the term loosely, ignorance is not an excuse for iatrogenic behavior and malpractice. The malpractice has been going on for so long that dentistry, I told you, created its own profession called denturism for those individuals to look after those clients that are continually not happy. They can be resurrected to some level of, let's say, satisfaction, but the steps here have to be adhered to, meaning centric relation in the proper vertical dimension with the proper vertical dimension of rest, in a Facebook transfer record, so we could locate the maxilla in relation to the condyles of a semi-adjustable articulator, a protrusive bite record as well, so we can determine the condylar guidance of each condyle of the patient, or at least an average of both. So therefore, if we have the condylar angle, then we can do the denture setup to have bilateral balanced occlusion, meaning no eccentric contacts, left lateral or right lateral, or in protrusive. This here is the secret recipe of full denture therapy. Now, I'm going back to the base plate as I was talking while I'm adding wax. As you can see, I'm free-flowing wax from the Bunsen burner. So if you have a pot of wax in front of you, make sure that it's kind of semi-molten. Make sure it's full of wax. It'll make your job easier. And most the most popular error I see, let's say the beginner tech or whatever, they don't use the wax hot enough. So this exercise is not just making an occlusion rim, is controlling wax in its molten state. As you notice, I don't have any wax on my hand. As I just said that, I dropped it on my thumb because I was talking with my hands. Perfect timing. As you can see, I don't have it on my hands. I don't have it on the desk. I don't have it on the model. Now, I've soaked the model as my separating agent for wax to a gypsum. And we know from dental materials, gypsum, calcium sulfate, hemihydrate, if it's saturated, the wax will not impregnate the stone. It will separate. Now, some of you out there saying, well, I used Vaseline. Vaseline has a medium to it, meaning a thickness. So therefore, I don't use Vaseline. Plus, I don't like the feel of it on my fingers. It's just not happy with that. You could use denture separator. That's the pink stuff. Acrylic separator. Again, that has a medium. And then when we put separator on the model, that may deflect the separator we're going to put on the model when we're heat curing. So these things I'm showing you here are systematic for a reason, not because, oh, Paul likes it that way, or the instructor likes it that way, or he drank the Kool-Aid from a certain dental technician to do it that way. This here makes sense. This here will give you results, consistent results. Now, you don't have to do this step now, but maybe by habit, I'm flowing free-flowing wax about 2 millimeters past where I believe the denture to finish. I'm going to have the patient go through exercises to deflect the soft palate, or the dentist will do this. So I can see where that vibrating line is. I can mark it with an indelible pencil if I want. I can visually see it. If I'm gagging the patient with wax, then I can trim the extension of the wax extension of the border shorter, chair side, without pulling out, a handpiece and a burr, which we know that's not a good thing, chair side. The dentist, I don't even know if they own a burr to trim it. It's going to make a mess. The patient's going to hear the noise. It wastes time. I think if we could be chair side just with a knife and a few instruments, that's enough. To do a proper bite registration, all 3 registration, is 4 units of time in the dental office. On average, that's 1 hour. Now, I would really like to challenge most of my dentist friends out there about if they're choosing to use 4 units of time for bite registration. Now, I'm going to explain those bite registrations here in a second. I'm making 22 millimeters as an average starting point for vertical dimension. As you can see here, I've flowed a good thickness of wax, and I'll smooth it out. I've even gone over the palate to keep the consistency smooth. Now, here's the next step. We've got our base plate short of the undercut, number 1. Number 2, it will not abrade the model. Number 3, the base plate's just the strengthener pretty much. If you do it all in wax, too flimsy. We need some kind of rigidity or stability to this occlusion rim. Next thing is we have wax. It comes in different hardnesses. So here we are at our school. I'm not sure. This one seems to be a little bit softer. Not necessarily a number 2 setup wax. But nevertheless, you have a choice to eliminate air bubbles. You can fold it. You can fold it to get rid of the air bubbles. So I just folded it once. You decide, you practice, you experience, you make it your own. You can roll it. Like, yes, a tobacco cigarette. I hear you giggling. But you can roll it. You can roll it. Okay. I'll stay on task. You can roll it. But the biggest thing I see the beginner dental technician is you're not using the wax molten enough. This wax should be so soft to the point where it's almost going to burn your hand. It's got to be almost falling apart. That's soft. So you can manipulate it where you want to. Okay? We are given the frontal lobe. The wax isn't. We control it. This is an inanimate object. When the wax controls us, that's frustrating. So I control the base plate. I control the model. I control the base of the model. I control the thickness of the wax. I control it. And I'm practicing it. When you lose control of it, I guess that's the difference between a bad day and a good day. Don't think like, oh, I'm going to own a lab and I'm going to give this for other people to do. That would be what a denturist would think. We're the dental technician. This is really not a big deal. 20 minutes, 25 minutes, half hour maybe to make a great bite block at the most. And